How do I know what my risk of relapse is?
A very, very important question. And the answer to that is evolving. The more we know about the disease biology, the more we can refine the risk of relapse. But in general, if we try to divide it into two groups, one is the features that are present at diagnosis or the pre-treatment features, right? And the second group, we talk about the post-treatment features. So for pre-treatment features, the risk categorization is possibly the most important thing. For AML, when we risk categorize it, we mostly base on the chromosomal abnormalities, and more recently, we're also including the mutational pattern in defining the risk stratification. So then you can define it by the European Leukemia Network. They have defined it into three groups: the favorable, intermediate, and high risk. Now, the intermediate risk, you can divide it into intermediate 1 or intermediate 2. But, those are more specifics. But in general, so those are the information that are incorporated, the chromosomal abnormality, number 1, and number 2, the mutation profile in defining the risk categorization. That possibly is the most important pretreatment feature that defines the risk of relapse. Now, the other possibilities are if there are organ dysfunctions, coexisting organ dysfunctions. Now, they not only can increase the risk of mortality from the induction treatment, but at the same time, because of the compromise on the intensity of treatment, because if you have say a kidney dysfunction, you might want to compromise on the dose of the chemotherapy. The same thing is true if there is a liver dysfunction. So sometimes the organ dysfunctions also dictate what intensity of treatment we can use. And if we cannot use the most optimal intensity of treatment, that also increases the risk of relapse. So those are more of the pre-treatment features. Now, the after treatment, when we assess for response, one thing matters quite a lot is the quality of response. There are different categorizations of response. You call it complete remission with incomplete platelet recovery, complete remission with incomplete recovery of counts, or quote-unquote CRP, CRIs. Of all the responses, achieving a complete remission is possibly something extremely important because that's a good quality remission. And that matters in the long run in terms of the disease coming back. Now we have been able to refine this a little more, mostly by use of minimal residual disease evaluation, whether you do it by flow cytometry or if there are certain mutations that are present at diagnosis, those mutations can be tracked over time. And so you can define minimal residual disease or measurable residual disease either by flow cytometry or by mutation profiling. And both are relevant in the appropriate context. So that's the depth of response. Complete remission is more by morphology, looking under the microscope, counting the blast and the blood count recovery, whereas the flow cytometry-based minimal residual disease or mutation-based minimal residual disease, it's a deeper dive into the quality of response. Those matter. Now, if you had abnormal chromosomes at the beginning, the abnormal chromosomes disappearing, that matters. So those are the post-treatment features that mostly are important in kind of predicting what are, the general chances of relapse.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take notes, and bookmark lessons. Visit the links in the description below to get started.